get started today. So welcome everybody to another Department of Medicine Inclusion Council presentation. I'm Minju, co-chair of the Inclusion Council, along with Dr. Alana Biggers, and we're so excited to have Dr. Zena Sharman join us today to speak to us about LGBTQ inclusive healthcare. This is a Richard Weber supported lecture, so we have to thank Dr. Weber for his continued support and being able to help us to continue to bring programming like this to the Department of Medicine. And we'd like to start with an introduction from Dr. Patricia Finn, our Chair of Medicine, and then Dr. Anna Maria Grammisbacher will be introducing our speaker today. So thank you and welcome everyone.
Thank you, everybody. It's a real pleasure to welcome all of you and particularly our guest speaker. As Dr. Minju said, our mission is really to train the next generation, exceptional care for all, with the thought of how do we actually live up to that mission in each and every event and task that we complete. And it's really in that spirit that our Inclusion Council has been so helpful in for our educational series. And it's really in that spirit that we're all here today. So I welcome everybody. I'm looking forward to our conversation. And I once again thank Dr. Richard Weber, who in the spirit of training the next generation is here today at this supported lecture.
Very welcome.
All right, so I will be introducing Dr. Zena Sharman today. For those of you that don't know me, my name is Anna Maria Grammisbacher. I'm one of the primary care physicians at UI Health. And I actually first found Zena on Twitter and have used her book, which I don't think you can see here, but it's the Remedy, the Queer and Trans Voices on Health and Healthcare in my Narrative Medicine course for students, which has been just so wonderful to help share some of these stories and these voices that we often don't hear. So Zena Sharman is a writer, speaker, strategist, and LGBTQ+ health advocate. She edited the Lambda Literary Award-winning anthology, The Remedy, Queer and Trans Voices on Health and Healthcare, and co-edited the Lambda Award-winning anthology, Persistence, Always Butch and Femme. Zena has presented on LGBTQ+ health at universities and conferences across North America. She has over 10 years experience in progressively senior leadership roles at health research funding agencies. Zena currently serves as the Director Strategy at the Michael Smith Foundation for Health Research and was previously the Assistant Director of Canada's National Gender and Health Research Funding Institute. Zena co-chairs the board of the Catherine White Holman Wellness Center, a holistic health center for transgender and gender diverse communities, and is a former board member of the Canadian Professional Association for Transgender Health. She has a PhD in interdisciplinary studies from the University of British Columbia, where her research focused on gender and healthcare work in the health system. Her resume also includes party thrower, cabaret host, go-go dancer for a queer punk band, campus radio DJ, and elementary school public speaking champion. We are thrilled to have Zena here with us today, and I can't wait to hear more from you.
Thank you so much, Anna Maria. And again, just really thank you for the opportunity to be here. I really want to invite folks. I know so many of us are spending so many of our hours each day sitting in front of computers, looking at Zoom, and I intentionally don't have PowerPoint slides. So if you want to just turn your camera off, if you want to just listen, close your eyes. I have a talk that I'll give, and I'm deliberately not giving you anything to look at besides my face, should you desire to look at it. So again, really, really glad and grateful to be here. And I really want to begin by acknowledging where I am, because we're connecting virtually today, as is so common for so many of us right now. Yet we also are people rooted in a specific place, time, and community. I'm coming to you from my home on the west coast of Canada, in the province of British Columbia, in a city called Vancouver. I moved here for grad school in 2001, intending to stay just for as long as it took to finish my degree. Instead, I came out as queer, built community, relationships, and chosen family. I became a parent and I'm raising a child here. Instead of transience, I found roots. I've been deepening and tending those roots for 20 years now. 2 decades feels long, but it's a tiny fraction of time compared to the thousands of years Vancouver has been the traditional, ancestral, and unceded territory of the Squamish, Tsleil-Waututh, and Musqueam nations. As a white queer person whose ancestors came to Canada from Scotland and Ireland, I am learning and practicing what it means to be a respectful guest on lands that don't belong to me and that have been stewarded by the Coast Salish people since time immemorial. I am learning and practicing what it means to be in a humble, reciprocal, loving relationship with the land instead of treating it as a lifeless commodity to be extracted and used. I am thinking about a conversation I had recently with a friend of mine who is Indigenous and who told me that rematriating land to the stewardship and care of the Indigenous peoples it was stolen from is fundamental to any policy solution she would offer in response to the health and other disparities Indigenous people face today as a result of colonization. I learned recently that the University of Illinois at Chicago resides on the traditional territories of the 3 Fire peoples, the Ojibwe, Odawa, and Potawatomi, and that Illinois is home to one of the largest and most diverse urban Indigenous communities in the US. I encourage all of us to remember and think about how colonization violently disrupted and deliberately severed vibrant Indigenous kinship networks, relationships with the land, and traditional practices of healing and ceremony. Colonization brought with it the imposition of a binary understanding of gender and a limiting heteronormative view of sexuality that didn't reflect the complex and varied ways Indigenous people across what is now called the US and Canada embodied and expressed their identities and desires. I begin this way because these histories and their present day impacts matter in conversations about LGBTQ+ health, and in how we each engage in the ongoing work of repairing past and present harms to build a more liberated future for every person, being, and the land itself. Envisioning this future requires tracing back through the histories that brought us to the present moment. It requires humility and accountability. It requires the courage and creativity we need to imagine a world different from the one we've come to accept as normal or inevitable. This commitment to imagining and creating a different world underpins a question I've been asking myself in my work as an LGBTQ+ health advocate. The question is, what if LGBTQ+ people loved going to the doctor? As healthcare providers, educators, students, and researchers, I'm sure you know how powerful a question can be. Asking questions can open us to new information and ideas. They can forge connections. Questions can be a portal into possibilities we hadn't yet imagined. This deceptively simple question, what if LGBTQ+ people loved going to the doctor, is a kind of portal for me because of how it gestures towards an audaciously different set of conditions from the ones we're in now. When I ask other people in the LGBTQ+ community this question, they usually laugh or make a face that tells me just how unfathomable it is for them to imagine loving going to the doctor. Even liking it is hard to imagine. But then when they think about it a little bit longer, something changes. As they contemplate what it would mean to feel this way, their facial expressions shift, their eyes light up, and their bodies relax a little. I know, because mine does too. There's something potent about this moment of shared imagining, even if we aren't picturing exactly the same thing, when we envision what it would look and feel like to genuinely love going to the doctor. This question leads me to other questions. What if LGBTQ+ people could always trust in getting the healthcare we need in ways that felt good to us? What if it felt safe enough to bring our whole selves into the process? What if healthcare felt healing and helped us flourish? What if the health system honored and valued queer and trans people's lives and bodies? What if our communities had the resources we need to create and sustain our own forms of care and healing in ways that are expansively available to everyone who needs them? What if all healthcare and healing was built on a foundation of anti-racism and disability justice? What if the care we received was rooted in a commitment to our liberation and the liberation of all people? What if? My intention in asking these questions is to invite us to shift our thinking beyond what we have learned to accept is possible. Answering them will require us to confront the reasons why hardly any LGBTQ+ person I know loves going to the doctor. It's not because of the long waits for appointments, scratchy paper gowns, or outdated magazines in the waiting room. It's because of an accumulation of experiences that leave people convinced they won't be treated with dignity, kindness, and understanding when they access healthcare. For many LGBTQ+ people, spaces like the clinic, the emergency department, or the therapist's office feel scary, traumatic, and violent, instead of being havens of safety, care, trust, and healing. LGBTQ+ people remember all the times they've been called by the wrong name or pronoun by a care provider, or were met with suspicion or disbelief when they tried explaining where it hurts and why, or given inadequate pain relief because someone wrongly believes their Black or brown body feels less pain than white bodies do. People remember feeling like they can't talk openly about drug use, sex work, or suicidal ideation because they're afraid they'll be judged, stigmatized, and at risk of being surveilled or incarcerated against their will. We feel like we can't show our whole selves to you. What does this mean for the patient-provider relationship and the care you're able to offer? Many LGBTQ+ people associate accessing healthcare with feeling invisible or too visible, or like nobody understands us, our bodies, our relationships, and who we call family. Far too many of us aren't able to get the care we need because we don't have enough money, or we lack health insurance, we're incarcerated or undocumented. How and where that care is offered is inaccessible to people with disabilities, or we live in a rural community where no one is trained to care for us. All this rolls up into a picture of inadequate, inaccessible, and sometimes outright harmful healthcare. Data from Canada, the United States, and Europe tells a similar story. LGBTQ+ people experience discrimination and barriers to healthcare, including outright denial of care. Trans people consistently report the highest rates of healthcare discrimination, around 20 to 30% of trans people, compared to around 10% of lesbian, gay, bisexual, or queer people. People who are racialized, Indigenous, disabled, poor, or fat also report higher rates of healthcare discrimination and mistreatment by care providers. We brace ourselves for the impact of discrimination. I notice it in how I steel myself before seeing a new healthcare provider, feel how I physically and emotionally armor up to mitigate against the possibility of harm. Research shows LGBTQ+ people avoid or postpone medical care, preventive screening, and trips to the emergency department because of fear of discrimination. Echoing the data on experiences of discrimination in healthcare settings, this is particularly the case for transgender people, around 20% of whom report avoiding healthcare, compared to around 10% of their lesbian, gay, bisexual, and queer counterparts. When we do access healthcare, we strategize about which parts of ourselves to conceal or reveal in order to be considered credible and worthy of care. In an essay called On Being Bipolar, non-binary writer Andrea Bennett, who uses they, them pronouns, tells the story of being a pregnant non-binary person with a history of mental illness. During pregnancy, they chose not to come out as non-binary to their OBGYN and other healthcare providers. Explaining their decision, Bennett writes, "I had a very strong urge to be as candid as possible about being bipolar so that I could be streamed into emergency mental health care if it became necessary. While being candid, though, I also wanted to appear as stable, as normal as possible. I did not know if I could afford to be non-binary and bipolar. I compromised." I am dreaming of a world where these kinds of compromises are unnecessary. I am dreaming of a world where LGBTQ+ people can be uncompromising, and our expectation that we can always access healthcare and healing with dignity, safety, and the joy that comes with being honored and valued in the fullness of our identities and ways of relating. I am dreaming of a world where LGBTQ+ people love going to the doctor, or the nurse practitioner, the counselor, the midwife, the massage therapist, the traditional healer, or any other practitioner we see, and where healthcare providers work under conditions that enable you to flourish while caring for your patients and clients. I am dreaming of a world where LGBTQ+ people who are Indigenous, Black, Latinx, Asian and Pacific Islander, mixed, or from other racialized communities can access healing and healthcare that centers and honors their intersecting identities and cultures. I am dreaming of a world where LGBTQ+ communities are lavishly resourced to organize community-led, peer-based healing, care, and mutual aid for each other. I am dreaming of a world with an abundance of LGBTQ+ elders, where we are surrounded by queer and trans people who are old and thriving, living alongside children being raised by families and communities who love them for the perfection of exactly who they are, honor their bodily sovereignty, and joyfully affirm however they choose to express their genders or sexualities at every stage of their lives. This is the care I dream of. This is the world I am working to help create. I know from experience it's possible to create this world because it's already here. These are not unattainable goals. LGBTQ+ people and communities and the providers who care for us, many of whom are LGBTQ+ people themselves, are already practicing and creating this kind of care, even as we work to transform the larger systems that often get in the way. I know some of you participating today are doing this work. Thank you for dreaming this world into being with me. The LGBTQ+ community has a long history of creativity, resistance, and mutual aid when it comes to our health and survival. We are adept at dreaming and building. I can think of an example from your own city, documented by historian Katie Batza in the book Before AIDS, Gay Health Politics in the 1970s, where Batza tells the origin story of the Howard Brown Health Center. David Ostro, a gay man who was then a medical student at the University of Chicago, was frustrated because his medical training hadn't prepared him for the health needs he saw in his community. In response, he created a support group for gay medical students experiencing homophobia in medical school. In 1973, Ostro placed an ad in the Gay Crusader, the local gay newspaper, with a phone number other gay medical students could call to join the group. His phone rang off the hook with calls from gay medical students and people from the gay community wanting to know where they could find good, respectful, non-judgmental healthcare. Remember, just a year before, psychiatrist and gay rights activist Dr. John E. Fryer gave a speech in disguise at the 1972 American Psychiatric Association conference. Wearing a mask and a wig and speaking under the name Dr. Henry Anonymous, Fryer shared his experiences and those of other psychiatrists who had had to hide their sexuality from colleagues out of fear of discrimination. Fryer himself had been kicked out of a residency and lost a job because he was gay. A year later, in 1973, the same year Ostro placed that newspaper ad, homosexuality was delisted as a mental illness in the APA's Diagnostic and Statistical Manual. By 1974, Ostro and the collaborators he met through the support group, including nurses, physicians, and medical technicians, began exploring the idea of offering medical services to the gay community, an idea that eventually grew into a community clinic. In partnership with local bars and bathhouses, their services later expanded to include community outreach in an RV known as the VD van. A drag queen clad in a nurse's uniform, Nurse Wanda Lust, often rode with the van and became its poster person. In the van, community members could access STI testing, visit with a drag queen, and be served cookies and milk, then head right back to the bathhouse or bar for the rest of the night. I share this story because it is one of myriad examples of healthcare by and for the LGBTQ+ community, and because I found it meaningful to learn these histories, to understand how the work I do today, the work we are doing now, is part of a lineage of activism, organizing, and community-led healthcare. It has been similarly important for me to learn about the health activism of groups like the Black Panthers, whose mission of serving the people, body, and soul included the creation of people's free medical clinics in cities across the US, sickle cell disease screening, free breakfast programs for children, and training of community health workers. If you want to learn more about this history, I encourage you to read Alondra Nelson's book, Body and Soul, The Black Panther Party and the Fight Against Medical Discrimination. Like the Black Panthers, Puerto Rican group, the Young Lords, also engaged in community health activism. They liberated a city-owned X-ray truck to screen community members for tuberculosis after the Tuberculosis Society repeatedly denied their request to use it. They also tested children for lead poisoning after hundreds got sick and several died due to an epidemic of such poisoning in their community. The Young Lords occupied Lincoln Hospital in the South Bronx, known locally as the Butcher Shop, because of the deplorable care it provided to Latinx and Black people. Working in coalition with healthcare workers, the Young Lords drafted the first Patient Bill of Rights and established the first acupuncture drug treatment center in the United States. One of the places you can learn more about this history is in the book, The Young Lords, A Reader, edited by Daryl Ingwanzer. I wonder if anyone taught you these histories in medical school or in your training. I wonder how learning about them might have shifted your perspective on what's necessary or possible when it comes to providing healthcare with and for communities experiencing systemic oppression. They certainly shifted mine. The title of this talk references a line from a translation of the Hippocratic Oath, "Keep them from harm and injustice." I chose it because I believe in your commitment to doing good and doing right by your LGBTQ+ patients. I chose it because in spite of this commitment, you are probably harming them, harming us, because few physicians and healthcare providers have been given the information and tools you need to offer the kinds of care I dream of to LGBTQ+ people and communities. The system wasn't built for us and we suffer the consequences. These are not abstract consequences. They are material and sometimes fatal. I chose this title for my talk today because I am attracted to the idea of healthcare providers rooted in a commitment to keeping their patients from injustice. I'm curious what it would look like to create a health system centered in a commitment to justice. And more than this, in a commitment to all people's liberation. The system doesn't exist today in your country or mine, but what if it did? How can we expand and shift our ability to imagine what's possible? If you study systems change, you may come across something called the iceberg model. The basic idea is that each system, including the health system, has different leverage points where there is the potential for change. These parts all fit together like the layers of an iceberg, most of which are under the water, out of view. What we see above the surface is just the tip of the iceberg, the events, what's happening out there. Maybe you remember a time an LGBTQ+ patient wasn't forthcoming with you or didn't come back for another visit, or perhaps you deemed them non-compliant. Just below the water are patterns of behavior adding up to trends over time. For example, the statistics I shared earlier about LGBTQ+ people experiencing discrimination in healthcare settings and choosing to delay or avoid care. Below these patterns, we find the structure of the system itself. Components like medical schools, where physicians in training receive little to no instruction on LGBTQ+ health, and LGBTQ+ medical students are more likely to report burnout, harassment, isolation, and lack of support. Experiences exacerbated by transphobia, racism, and ableism, as well as hospitals, insurance companies, and all the other parts that make up this complex entity we call the health system. The deepest part of the iceberg is where we find mental models, the values, assumptions, and beliefs that shape a system. These tend to be less perceptible to us because they are so implicit, yet they have a huge impact on how the entire system functions. Think, for example, of how often LGBTQ+ health is framed in terms of risk mitigation, or the stigma attached to sex work or drug use, or who you picture when you imagine a good or compliant patient. Systems change practitioners will tell you that our mental models, the very deepest part of the iceberg, in the depths of the waters we are all swimming in, are the most difficult and thus the most powerful to change. By reorienting our conversation to dreaming, my intention is to invite us to change our mental models. It matters when you wear a pronoun badge on your white coat or ensure your forms are inclusive of diverse gender identities and sexual orientations. It matters, and I want you to do this, but I also want us to remember it's not enough. We can and must dream differently, and we must act from a commitment to liberation. We are almost a year into the coronavirus pandemic. Our new normal is anything but. I am feeling this abnormality more acutely today as I remain inside my home, halfway through a 14-day self-isolation period after a close family member of mine tested positive for COVID last week. I can't imagine the bone-deep exhaustion some of you must be feeling at this moment. The trauma, compassion fatigue, and moral distress that must come along with being healthcare providers in the face of so much devastating and preventable illness and death among your patients, your community members, your colleagues. I wonder who among you is feeling incandescent rage, immobilizing fear, frozen numbness, crushing heartbreak, or an all-pervasive grief. I wonder who among you is sick and tired of being called heroes because that is not what you signed up for when you chose this profession or this educational path. I wonder how many of you wish you could just lay down and rest for a while, and how many of you are scared you might not get back up again if you did. I wonder how many of you push forward anyway because it is your duty and because it's what you've been trained to do, sometimes to your detriment or that of your colleagues, students, patients, and loved ones. I wonder how many of you are being invited to mandatory wellness workshops or given self-care tips instead of having the resources, supports, and conditions you need to work and learn safely and sustainably. In the face of all of this, I wonder what brought you here today. I'm grateful you showed up. I say this because I'm interested in creating a feeling of connection, empathy, and solidarity between us across miles, technology, and differences of identity and experience. The truth is, I don't know how it feels to be you in this moment, just like you don't know how it feels to be me. I am many things. Foremost among these, I am queer and I am a writer. I have been writing my way through the past year, trying to make sense of what's happening around me and what it means for the LGBTQ+ community and the privileged position I hold as someone some people look to for ideas about what needs to change. My answer has increasingly become everything. Some of you may be familiar with the quote, "Every system is perfectly designed to get the results it gets." I've been sitting with the immense truth of these words as the coronavirus pandemic has unfolded around us, killing over 460,000 people in the United States, more than 20,000 people in Canada, and over 2.3 million people globally, while also leaving others with long-term illness, not to mention the social, emotional, and economic consequences of the pandemic faced by countless people around the world. These burdens are being disproportionately borne by poor and racialized communities and by elders and people with disabilities, including in your own city, where Black and Latinx people are sick and dying of COVID at much higher rates. LGBTQ+ people's physical and mental health and economic security are also being disproportionately impacted by the pandemic. This is not an accident of fate. It is a predictable outcome of a health system and a society built upon a legacy of racism, ableism, and systemic oppression. We are living, working, and learning under unprecedented conditions that are pushing people to imagine and demand more foundational change, like the recent upswell of support for calls to defund and abolish the police, a form of widespread awareness that builds on decades of organizing by leaders in Black and other communities affected by policing and mass incarceration. There have been many moments over the past year when I have struggled to make sense of what is happening around me, when I have felt so freighted with grief I couldn't fathom what to say or do that could possibly make a difference in the face of such overwhelming and inequitable devastation and death. Even today, I'm conscious I'm talking about dreaming and calling for systemic change instead of offering you a neat list of tangible actions you can grasp onto. This is because I don't have neat solutions, and because I'm interested in learning more about all the ways you can imagine caring, teaching, and learning from a commitment to liberation. I'm interested in thinking and dreaming together with you about how we can all become agents of change inside and outside a system desperately in need of transformation, and then putting those dreams into action in service of our shared commitment to LGBTQ+ health. Thank you.
So thank you, Dr. Sharma. Thank you, Dr. Weber, again for sponsoring this, and Dr. Finn for supporting the DOM Inclusion Council. I'll see many of you at the 4 o'clock session. Thank you.
Thank you so much.